Artificial Intelligence Doctor www.abcpharma.net/English. User question. What is the significance of the diagnostic gray zone of PSA levels 4.0 to 10.0 nanograms per milliliter? And how should clinicians approach patient care when PSA levels fall within this range? Claude AI. The diagnostic gray zone of PSA levels 4.0 to 10.0 nanograms per milliliter represents a critical area of clinical decision-making in prostate cancer screening and diagnosis. This range is significant because it presents a particular challenge in interpreting PSA results and determining the appropriate course of action. Let's break down the importance of this range and how clinicians should approach patient care. Significance of the diagnostic gray zone. 1. Overlap of benign and malignant conditions. PSA levels in this range can be indicative of both benign prostatic hyperplasia, BPH, and prostate cancer. Approximately 25–30% of men with PSA in this range will have prostate cancer on biopsy. 2. Risk of overdiagnosis and overtreatment. Indiscriminate biopsies in this range can lead to the detection of clinically insignificant cancers. This may result in unnecessary treatments and associated side effects. 3. Risk of missing clinically significant cancer. Conversely, not investigating further might miss aggressive cancers that require prompt treatment. 4. Age-related considerations. The significance of PSA in this range can vary with age, as PSA naturally increases with age. 5. Individual variability. Factors like prostate size, inflammation, and recent interventions can affect PSA levels in this range. Approach to patient care. 1. Comprehensive risk assessment. Consider other risk factors: age, family history, ethnicity, prior PSA velocity. Perform a thorough digital rectal examination, DRE. 2. PSA kinetics. Evaluate PSA velocity, rate of change over time. Consider PSA density, PSA level relative to prostate volume. 3. Additional biomarkers. Consider using free PSA percentage or PSA isoforms. The Prostate Health Index, PHI, or 4K score can provide additional risk stratification. 4. Imaging. Multiparametric MRI can help identify suspicious lesions and guide biopsy decisions. Consider prostate volume assessment via transrectal ultrasound. 5. Shared decision-making. Engage in detailed discussions with patients about the risks and benefits of further investigation. Consider patient preferences and anxiety levels. 6. Risk calculators. Utilize validated risk calculators, e.g., ERSPC risk calculator, PCPT risk calculator, to estimate individual risk. 7. Repeat testing. Consider repeating PSA test after a few weeks to rule out temporary elevations. Ensure proper pre-test conditions, e.g., no recent ejaculation, urinary tract infections, or prostate manipulation. 8. Age-specific considerations. For older men, greater than 70 years, consider life expectancy and comorbidities in decision-making. For younger men, consider the long-term implications of potential diagnosis and treatment. 9. Prostate biopsy. If biopsy is deemed necessary, consider MRI-guided or MRI ultrasound fusion biopsy for improved accuracy. Discuss the risks and benefits of biopsy with the patient. 10. Active surveillance. For patients who undergo biopsy and are found to have low-risk cancer, consider active surveillance as an option. 11. Referral to urology. Consider referral to a urologist for specialized evaluation and management. 12. Lifestyle interventions. Discuss potential lifestyle modifications that may impact prostate health, e.g., diet, exercise. Challenges and considerations. 1. Psychological impact. Acknowledge and address patient anxiety related to uncertain PSA results. 2. Cultural and ethnic variations. Be aware of potential differences in PSA interpretation based on ethnicity. 3. Economic considerations. Balance the cost-effectiveness of additional tests with their potential clinical benefit. 4. Evolving guidelines. Stay updated on changing recommendations from professional organizations. 5. Personalized medicine. Consider emerging genetic and molecular tests that may aid in risk stratification. Conclusion. The diagnostic gray zone of PSA, 4.0 to 10.0 nanograms per milliliter, requires a nuanced and individualized approach. Clinicians should utilize a combination of clinical judgment, additional diagnostic tools, and shared decision-making to navigate this challenging area. The goal is to balance the risks of missing clinically significant cancers with the potential harms of overdiagnosis and overtreatment. As our understanding of prostate cancer biology and diagnostic tools continues to evolve, approaches to this gray zone will likely become more refined and personalized.